Welcome to Glass Plates to Deep Learning, Imaging Processing, presented by Mark Struthers. Medical imaging creates images of the human body for diagnosis and treatment. Information about the body is acquired for visual display. Optimizing the information we acquire for creating the images allows us to interpret the images with more confidence. Poor quality images result in poor quality diagnosis or a misdiagnosis. Today we'll look at image acquisition, processing, and post-processing of image information. Technologists or radiographers must optimize image acquisition. Without optimized images, the interpreting physician has difficulty in providing the best quality services to the patient. To create medical images takes an integration of technology and highly trained people. Over the past 100 years plus, we've seen an evolution in medical imaging. Image capture techniques and display are different for digital imaging and traditional medical radiography, which uses photographic processing for film. Here we see a glass plate image that was done in 1912 and modern monitors that display digital images. Different times and different technology. Today's radiographers or technologists require a completely different set of skills to be able to capture digital images, especially with the evolution of technology. Many of the processes for acquisition and display are now automated, but the radiographer must understand the complete process to be able to produce quality images. Interpretation is directly related to the visual display of images. Is there a difference between the display of a light box with a film and a digital monitor? And is there a difference in the quality of the digital monitors used by the radiographers and the radiologists? Other than simple post-processing techniques such as annotation, post-processing should be done on the quality monitor that the image is going to be viewed for diagnosis. The quality of the diagnosis is very dependent upon the image and the skill and knowledge level of the person that is interpreting the image. To aid with interpretation over the last 10 or 20 years, we use computer-aided diagnostics, and today we've gone into deep learning and artificial intelligence to be able to support the interpreting physician. With the evolution of medical knowledge and technology, medical imaging is more important than ever in patient diagnosis and treatment. The evolution in medical imaging has also affected the acquisition technology, and today we're using both individual systems and integrated hybrid systems to get the information we need to diagnose and treat patients. This means there should be a dramatic difference in the training and skills of a radiographer using digital imaging as compared to the radiographer who used film screen processing. Patients and patient care have remained pretty much the same, but the ability to acquire images and to be able to interpret images has changed dramatically over the last 100 years. Medicine has also evolved from a reactive to a proactive type of science. So we're trying to find and diagnose diseases and pathology much earlier than we have in the past. With the aid of computers and other technology, this is something we're able to do with a high degree of skill today and probably a much higher degree of skill in the future. The knowledge and skill levels for healthcare workers must parallel the evolution in both medical knowledge and technology. Technology, deep learning, and artificial intelligence are now the tools of the radiologist and radiographer. Prior to computerization and using film screen technology, most of medical imaging was a manual process and very laborious. With computerization and automation, we're able to acquire millions of images and interpret them in a fraction of the time that it used to take us during the manual system, which was film screen radiography. The computerization of medical imaging has changed the workflow and also the skills required to accomplish the work. Automation has also changed the acquisition of images. Today, many of the images are what we call point-of-care imaging, where the physician actually creates the image in the emergency room or on-site or in their office. Because we have point-of-care acquisition, we must also be able to communicate these images very rapidly, and we do this over the internet or a computerized system. The responsibilities for radiographers to process images have completely changed because the medium has changed from film screen to digital. We don't worry about our processor jamming anymore with film, but we do worry about the packs going down. Today's radiographer must understand the theory and how imaging is produced in the computer system to be able to optimize the acquisition of the images. Just as we used to have to know about film and chemistry and exposure, today we still have the same responsibility, but it has evolved into knowing about digital acquisition and display. Since we're trying to create the optimum image display, contrast and the quality of the image is our main focus. We don't have to take multiple images today, but we do have the ability to take the data that we have from our acquisition and create multiple images. One of the most powerful attributes of digital images is that their displayed appearance can be changed. The appearance of the image can be modified by manipulating the lookup table or how we map the image to display. In film screen, all of the anatomy was superimposed. With digital imaging, we can choose the anatomy we wish to display, and we can modify its contrast and brightness to be able to emphasize different areas of physiology as well. Remember, whether it's a film screen image or a digital image, that image is merely a snapshot in time of that patient's condition. Today we can look at not only 2D images, but 3D images and 4D images, which represent images over a period of time. All medical images are a result of recording the interaction of energy with tissue. Separate imaging modalities record the energy at different levels or megahertz on the electromagnetic spectrum, such as ionizing radiation for X-ray and CT, radio frequency waves for MRI, sound waves for ultrasound, and gamma radiation for nuclear medicine. Each of these provides a different aspect of visualization of the tissue. Obviously, with ionizing radiation, we get good anatomical visualization. With MRI and radiofrequency, we not only get excellent soft tissue, but we also can utilize physiology and look at spectroscopy. Sound waves give us ultrasound, which gives us an excellent image in motion and real time. And nuclear medicine or gamma radiation allows us to see the physiology or the tissue actually working. In the past, when we used film screen capture, each of the modality's images were captured uniquely for that modality. Today, we're able to use hybrid imaging or be able to incorporate the information or the data from each one of these imaging acquisition devices into an image. Remember, to create images, what we're trying to do is to record the interaction of some form of energy with tissue and be able to visualize that. All energies are represented on the electromagnetic spectrum, and they are just different frequencies. So therefore, they are all represented by sine waves. Obviously, when we look at images, we can't see X-ray. We can't see ultrasound. We can't see UV light. We can't see any of the gamma ray either. So what we're doing is converting these energies into images that we can see. Since the only differences in the actual energy is the megahertz or the frequency of the cycling, it is very easy to do with computers and digitization. No matter what type of energy interaction with tissue we're recording digital data. And digital data can be manipulated to create images. Not only can the digital data be manipulated to create images, we can combine data to get more information from our images or add or subtract specific data from the images to get different types of information. This is called hybrid imaging. Let's take a moment to just review some images that demonstrate hybrid imaging and the utilization of digitization to emphasize different areas of the anatomy and physiology. Here we see hybrid images, where we're taking the data from different types of modalities and combining them. We can also see that it gives us the full control to manipulate these data. Because the data is collected in 3 dimensions, we're actually able to take the entire block of data and select different images from the data to be able to visualize those. Here we can see a histogram being pulled up. A histogram is nothing more than an area that demonstrates the intensities that were recorded. We can select intensities or window and level the data to create all different types of images. We can also be able to manipulate that data by zooming in, zooming out, and annotating. So we may take a look at just vasculature, or simply tissue, or bone, or a different combination of all 3. Based on the data collected, we can do a variety of images with the same data, demonstrating all kinds of different pathology and anatomy. The interaction of energy with tissue is quantified and it is digitized as to location and intensity. And this gives us the data or the information we need to create diagnostic images. Obviously, the acquisition of data is different for film screen capture than it is for digital capture, and particular to each modality, what type of images we are capturing. This means we need to understand our capture techniques and what they result in as far as data so that we can manipulate the data. Technique, or how we capture the data, is extremely important, and it differs with each modality and the goal of each exam. Film screen capture and interpretation is different than digital imaging modality capture and interpretation. In digital imaging modality capture and interpretation, data is captured, data is then manipulated, and data is then stored. Each of the data processes are unique unto themselves, and we integrate them to get our final results. Radiographers are primarily focused on capturing the data or utilizing the imaging modality to capture the data, but must understand the entire process. Let us review taking continuous energy and changing it or digitizing it. As we said, the waveforms of energy are continuous. A digital or digitization of this waveform requires us to be able to express energy in numbers. When we capture the energy, the continuous energy is known as analog signal. This analog signal needs to be sampled so that we can average the different intensities. Each of these averages is given a number. This is what we mean by digitizing an analog signal. These numbers represent the intensities and are used to map the images onto an electronic matrix. Now that we have it mapped, we have a matrix or a square with rows and columns of numbers in it, but it doesn't give us any idea of visualization. And since we view things visually, what we need to do now is take this analog to digital conversion and reverse it. Using what is called a lookup table for the different intensities that we want to take from number and put them back into luminance, we go ahead and make each one of the numbers a specific brightness or luminance. Combining this luminance, we actually are able to see an image on a monitor. We're changing the digital back to analog, visible light. Although the computer has massive amounts of data, we need to take that data and change it to a visible light because humans can see in 3 dimensions and they can only see in the visible light spectrum of the electromagnetic spectrum. Selecting the data we wish to visualize is the basis of digital imaging. Positioning the patient and setting technique allows us to collect the information for interpretation. Most things in the real world are continuous or analog. Everything in a computer is discrete or digital. The process of mapping continuous function to a discrete one is called sampling. The process of mapping a continuous variable to a discrete one is called quantization. This is where we give it a number. When we represent or render an image using a computer, we must both sample and quantize the information. This is known as analog to digital conversion. There are 3 steps in converting analog to digital. The first step is sampling, or taking samples or measurements of continuous time signals at discrete time instants. The next step is quantization, or assigning a value to each discrete time signal. The next step is coding the numbers, in other words, taking the digits and putting them into binary code which the computer reads. We then take the analog to digital conversion and reverse it so that we can get a visual display. So we're going to be converting the digital to analog or visible light that we can view. We select the brightness from our digital to analog conversion to create the display. This display represents the image that we have selected to view. The word pixel is a contraction of picture element, and the word bit is a contraction of the words binary digit. Each pixel can only be one color or one shade of gray based upon the intensity that we've selected. We create our image display by mapping the pixels, which represent the coordinates of the intensity in our interaction of energy with tissue on the patient. The intensity of the interaction is represented by bit depth. So the number of intensities that we can select from for our pixel is represented by the bit depth of the information selected. Another way of stating this in a black and white image is the bit depth is the number of shades of gray that you can select from to fill the individual pixel. The more shades of gray you can select from, the better quality detail you will see in your image. In other words, you're recording more precise information. The American College of Radiology states that a 10-bit depth is the minimum amount of contrast that we can utilize, or information that we can utilize, to create a diagnostic image. In an image where we need more information or detail, such as a mammogram, we use a 12 to 14-bit depth. Let's clarify this with another approach. We'll use grayscale values to create a grayscaled image or a radiograph. And today we're going to do a radiograph of the elbow. Let's look at how the pixels create contrast. Next, we'll see how the bit depth assigns an intensity or shade of gray to each pixel. Next, we see the matrix, which gives us the coordinates in rows and columns of each one of the pixels. Finally, we map the coordinates of the information that we've selected onto the matrix to create the image display. Each one of the coordinates reflects the position of the information that we've got on the interaction of energy and the intensity of that energy at that point. The image is displayed as a combination of rows and columns known as a matrix. The smallest component of the matrix is the pixel or picture element. The smaller the pixel or picture element, the better the quality image or the more detail we can see. The location of the pixel within the image matrix corresponds to an area within the patient or volume of tissue referred to as a voxel. The voxel represents the intensities that we've recorded and their corresponding shade of gray. Now let's look at a practical application. We'll take a look at a CT slice. As the scanner rotates, it has a detector that takes a number of snapshots called profiles. Typically, there are about 1,000 profiles are taken in one rotation. Each profile is analyzed by a computer, and the full set of profiles from each rotation is compiled to form a slice or a two-dimensional image, which is made up of a matrix of pixels and voxels or shades of gray that correspond to the tissue interactions. This is a simple representation of how a digital image is created. A histogram or a sinogram is the map coordinates for the shades of gray that we would like to see. Here we can see that the intensities are mapped utilizing different shades of gray to represent different intensities. This is the raw data captured from the interaction of energy with tissue. We take this raw data and we store it in the computer so that we can select from the raw data to create our image. The raw data is stored in rows and columns that represent the brightness and intensity of the interactions. So what are we going to do with this data? Well, we're going to process the data. This is called image processing. Now, in our image acquisition, we get the raw data. But do we want to utilize all this raw data because there are some artifacts and different problems within the raw data that come from our hardware and the acquisition? No, we'd like to get rid of these artifacts and all these problems. So we do that with pre-processing. And this is where we get rid of the dead pixels, we calibrate, we look at the shading and signal amplification, we clean up the data. Now the data is cleaned and displayed and we have an image. But is that the image we want? Maybe not. And this is where post-processing comes in. In post-processing, you can add and subtract data and have different combinations of data to give us different types of displays or images. So as we stated earlier, we have the acquisition, but we can make a number of different image displays from the data that we got in that one acquisition. We can even annotate the images for easier communication. After acquiring the image, the first thing we do is pre-process or filter the image, and this can be done with enhancements such as smoothing and sharpening. We can also interpolate the image, reduce noise, or crop the image to a specific area. Now we have the data. What we need to do on an intermediate level is segment the data, or take a look at the specific data that we wish to view. We can take a look at the data either by region or by shape. We're now going to take the data that we have and actually extract the data out, labeling it, and putting it into groups so that we can formulate or map the data into images. So we have our acquisition or input, but now we need a display or output. And taking this information that we've selected, we use another set of computer processes to create the image for display. When the image is displayed, it is then interpreted and put into the information system for distribution, or create our original image. So let's discuss values of interest. As the name states, values of interest, these are the values that we want to utilize in creating our image. These are the values where we look at the anatomy and we select how we want to visualize the individual pixels and map them to create the display. Pixel density, or the number of pixels that comprise the gradient, are extremely important. Pixel density is important. If we only had 2 pixels on our matrix, we could only record either 2 shades of gray or 2 colors. There'd be contrast, but there wouldn't be a great image. When we talk about pixel density, we're comparing the number of pixels in the exact same matrix or square size. The greater the number of pixels and the smaller the size, the greater the detail. Pixels represent height and width, but they do not represent depth. Voxels represent volume or depth. When we're talking about depth, we're talking about, obviously, the thickness of the image that we're looking at. This thickness can be referred to as a slice. Again, when we talk about the detail, the more the slices there are in a given depth, the greater the detail. Putting the rows and columns together and slices together, we get a volume set. Let's analyze this image. You'll notice that at 10 to the 9th, we have 1,000,000 pieces of information that we can put into the volume. Conversely, if we had 10 to the 1, we'd only have 10 pieces of information stored. So as you can see, in a volume of data, the pixel size and the slice size makes a difference in the total amount of information that we can store. Thin slices and lots of pixels allow us to choose a large amount of information to display on our image. This representation will help us in trying to understand how we create an image. Let's begin by looking at the chest X-ray. The chest is the same, but notice the contrast and brightness changes in the image. If we were to make a colored image, we would use the primary colors red, blue, and green. If we combine any 2 of those colors, we get the secondary colors, or cyan, magenta, and yellow. Pure black is a total of all the colors combined, and pure white is an absence of all the color. When we see a black and white image, we have what is called a grayscale, which is the scale from absence of color to full color, from white to black. The shape of a histogram is specific to the map of densities that we wish to make. A chest is different from a knee, etc. Here we see a simple histogram which maps the pixels by number and intensity. Here we can see that the shape of the histogram is the same for the chest in all of these images. Visually, these chest X-rays differ because of the information that we've chosen from the histogram to display. Detail in an image is dependent upon the size of the pixels and the dynamic range or the shades that go between black and white. The dynamic range is expressed in bit depth or the number of shades of gray. Histogram equalization is a powerful point processing enhancement technique. It seeks to optimize the contrast of an image at all points. Recall, a histogram is a table that simply counts the number of times a value appears in some data set. Here we have a graphic representation of the differences in the dynamic range between 1 bit and 16 bits. The point of this discussion is that when we acquire the correct information and a volume of information, we can selectively choose and create images based upon our desire to express data. After we get the original data that corresponds to the requested histogram, say a chest X-ray, we can go back in and manipulate that data. This is called post-processing, where we're selectively choosing data to represent the areas of interest. The physician or the radiologist will interpret the images on a display monitor. These are diagnostic monitors used for interpretation. They range between 3 and 5 megapixels in size. This gives us the detail that we need to make a diagnosis. Now we're looking at a QC or a modality monitor, which should be used for acquiring the imaging, but not for post-processing the images. The QC monitor usually has between 1 and 1.5 megapixels in its resolution. Referential monitors are used for physicians, nurses, healthcare professionals, and patients to look at the images. Because of cost, these monitors are usually of an inferior resolution for reference. Have you ever created a picture using a paint-by-numbers set as a child? If you have done this, you'll notice that you had to paint within the lines. That would be our detail. And at the same time, you had to paint with the appropriate number. That would be our intensity. When you wanted to create another picture, you would need another image because of the shape. In essence, we've just talked about the functionality of a histogram. Each histogram is unique to the exact image that you want to take at that specific point in time. Let's get a little bit more technical. Let's talk about anatomic programming. With anatomical programming, when you select an image to acquire, the position and the type of exam is listed, also the patient's size. So it may be PA chest adult large, PA chest adult small, PA chest pediatric. Notice they're all PA chests, but they are unique images. Each has a specific histogram. For every position and part, we have a histogram that is a unique paint by number that you want to utilize to capture that image. When you select a large adult PA chest, you're actually using a reference histogram lookup table to create the image. Image segmentation. In computer vision, image segmentation is the process of partitioning a digital image into multiple segments. This is similar to taking your paint by number and dividing it into different areas that would have a specific color. The goal of segmentation is to simplify and/or change the representation of an image into something that is more meaningful and easier to analyze. Histogram analysis is usually required before doing segmentation. It is a pixel-based technique. Let's begin by analyzing this image. We start with the system's dynamic range, and it shows this exposure that was made from 0.1 to 100 millirentgens. In this exposure, we can see the unused dynamic range and the range in which we want to select the features to create our image, which is called values of interest. Here we see the histogram, or the map that we would like to make to create the display, or fill in the paint by numbers. When we look at a histogram and the range of the histogram, say, is between 0 and 50, and most of the image is dark, we can adjust that image. We can adjust the image using the brightness control to lighten or darken the image. If we lighten the image, we're able to see more shades of gray, or we're expanding the shades of gray that are visible. Conversely, if we choose to darken the image, we are reducing the number of shades of gray. Once we have the shades of gray that we'd like to see, we can actually change the contrast. By moving the contrast, we will see the H&D curve move along the histogram. Remember, we're looking for the straight portion or gradient portion of the curve to be the area of contrast. Here we see the original image and the histogram demonstrating the shades of gray from black to white. Next, we can demonstrate only black and white intensities and get a binary image. Using the binary image, we can demonstrate the lungs only. We can look at the lungs filled in with shades of gray, replacing the black and white. This example shows that if we have just black and white, we need some sort of mapping to see how to distribute the black and white densities over the image. The shape of the histogram tells us exactly how to map the images, and that is why each view for the part being examined has a unique histogram attached to it. Chest for chest, knee for knee, abdomen for abdomen. Using a histogram and mapping the intensities using a lookup table, we're actually able to create an image. Here we can see an H&D curve placed over the histogram. Note the line portion of the H&D curve is the area of interest. Using our brightness, we can move the H&D curve over the histogram to select more or fewer shades of gray. This is our brightness control. Using our contrast control, we can change the slope of the H&D curve to give us more contrast or less contrast in the selected area of interest. Our computer also lets us sample the number of pixels that we wish to view in our histogram. Here we're sampling 1 out of every 10 pixels to view. We could increase the data in the image by sampling 1 out of every 5 pixels for viewing. Or we can take a look at all the data in the image. This means we have complete control over what we would like to select to visualize. After selecting the data that we wish to visualize, or the values of interest, we can then modify how they look by manipulating our contrast and brightness, which is demonstrated with an H&D curve that is superimposed on the histogram on which we're working. Lookup tables, or LUTs, are fundamental to many aspects of image processing. An LUT is simply a table of cross-references linking index numbers to output values. With definite outputs for every input, we have a lookup table, because the memory device simply looks up what the output should be for any given combination of input states on the histogram. Here we can see the difference in choosing different data to look at. From a normal chest x-ray, we can actually look at only soft tissue or bone if we wish. Here we see a chest x-ray, and we also are able to look at histograms. The histograms are set up for shades of gray, or we can combine the primary colors histograms, red, blue, and green, to end up with a color image. No matter what combination we select, we can also always change the contrast and brightness by moving our H&D curve over the histogram and changing its slope. When we capture an image, we can take a look at the image capture on our modality monitor, and we can adjust the image prior to sending it for post-processing. This optimized image then becomes the image that the radiologist receives on the PACS and that they can post-process. There is one caveat with this. You can actually manipulate out pathology. So be aware of what you're looking at and what you are doing when you are actually utilizing your brightness and contrast control on your image. And be forewarned, what you see on your monitor is not applicable to what the radiologist sees on their high-quality diagnostic monitor. Here we can see how we can adjust an image acquisition to save repeating the exam. By moving the slope of the H&D curve over the body of the information, we can save the image. The two peaks show us the code values, or the range or dynamic range of the pixels that were captured. On this image taken with CR, you'll notice the tall peak. This is the area that is directly on the plate and outside the anatomy, but within the collimation. While the short wide peaks indicate many shades of gray and usually represent the anatomy. The data acquisition methods used in imaging play an important role in image formation. Good technique selections means we will have the data that we need to create our images. The data collection methods become a decisive factor in determining the best temporal and spatial resolution for our images. Image processing and analysis methods are aimed at the enhancement of diagnostic information to improve manual or computer-assisted interpretation of medical imaging. Imaging processing means to transform images into new images. The simplest image processing treats every pixel independently. After we acquire the images, they are pre-processed to eliminate any artifacts. These artifacts may be specific to the modality or to digital imaging in general. These include pixel defects, sensitivity variations, and offset gain variations. The other part of pre-processing is to eliminate all data gathered except those values of interest. We're looking at the values of interest in the dynamic range to be able to post-process. Our pre-processing includes correcting flaws that are inherent to the detector and also the equipment. Radiographers' expertise in acquiring images allows them to create images that have a minimal amount of pre-processing required. A knowledgeable and skilled radiographer can work around or eliminate any inherent flaws with the modality detection. Skilled radiographers understand technique and its application. The ability to create a medical image is creating images by taking the raw image through a series of steps before it is ready for display or presentation. The foundation for all images is the acquisition of the information to create the image. This includes selecting the right modality, the right exposure techniques, and also in positioning the patient correctly to optimize information. In creating images, we know that there is additional work required before the data output from the image receptor is going to be useful. Here we're looking at the type of processing algorithms and what goes into pre-processing the data. So we can actually end up with, say, with CT, utilizing iterative reconstructions as opposed to the traditional back projection. Using iterative reconstructions gives us a much better quality CT image at a lot lower exposure. It's the responsibility of the radiographer to input the type of processing that they need to optimize the image prior to making the image acquisition. There are a number of choices and combinations of choices for the radiographer to make prior to making the acquisition of the data. Positioning and technique selection make a dramatic difference on the image acquisition and post-processing. Post-processing should never replace proper technique and proper positioning. It is preferable to repeat an exam rather than trying to correct a poor quality exam for diagnosis. We post-process images to improve the usability of the digital image for interpretation. This includes imprinting demographic overlays, adding annotations, applying borders and masks, flipping and rotating, increasing magnification, or co-joining images for special examinations like scoliosis. We can also modify the sequence of the views presented. This type of post-processing is done at the modality, but may require a separate workstation in some cases. This image is then sent to the radiologist or interpreting physician to be able to interpret the exam or do additional post-processing to the images. Post-processing at the modality serves a secondary function as well, and this is processing to customize contrast in the region of interest. This type of image processing includes modifying the image to enhance the contrast and sharpness of some features while compromising the contrast and sharpness of others, as well as modifying the image itself. This secondary image processing is applied in a manner that is usually specific to the anatomic projection being examined. Misuses of image post-processing include compensating for poor calibration of acquisition and display devices or surreptitious deletion of non-diagnostic images. Image processing or post-processing to recover non-diagnostic images to prevent re-exposure should be a last resort. Remember, these are non-diagnostic images, but if the patient dies on the table or there is some other tragedy, you may have to make the best of a bad situation. If you're forced to process most images prior to sending them to the radiologist for interpretation, it would indicate that you're having a problem with your equipment or technical practice. Beyond computer-aided diagnosis, today's radiologist has the advantage of deep learning and artificial intelligence to help them interpret images. We began several years ago with computer-aided diagnostics, or CADs, and this has evolved into deep learning. Deep learning is the computer itself system learns and evolves by itself. It refines all of the different searches continually, optimizing at all times. Computers are great at standardizing and selecting data and refining the data searches. Your computer has deep learning in that it creates better data from the data that you have input, but it also takes the data it is networked with to enhance this database. The function of computers is to rapidly develop and process data. Computers are phenomenal at analyzing large quantities of data in short periods of time, but they're horrible at making a decision. On the other hand, interpreting physicians and radiologists are not capable of analyzing large amounts of data in a short period of time, but they are very good at making a decision. So there is a synergy between the computer and the human. The computer does the heavy lifting as far as sorting and going through data, and the human takes the data that has been sorted and gone through and makes a decision. We are attempting to create algorithms for artificial intelligence, which will approximate the ability of a human to make decisions, but we're not there at this point in time. So the role of the computer is to sort images from a huge amount of data and provide images for a physician to make a decision upon. Let's take an example to demonstrate this process. There are different characteristics between a benign and malignant tumor. As the tumor grows, or neoplasm grows, the benign tumor or neoplasm pushes aside tissue or displaces tissue. It does not invade. While a cancerous or malignant tumor destroys and invades neighboring tissues. The periphery or the edges of tumors differ whether they are benign or malignant. Remember, the malignant periphery is invading and destroying local tissue, whereas the benign is displacing the tissue. So there is an interface between the benign tissue and the normal tissue. There is no interface between the malignant tumor and the tissue that is surrounding it, because the tumor is invading the surrounding tissue. When looking for cancer, we're trying to find the cancer as early as possible for a more successful treatment. Taking the information we know, how big would the tumor have to be for the radiologist to clearly visualize the periphery, whether it's benign or malignant? Now let's take a moment and think. A computer does not have vision. A computer takes statistics and analysis and makes comparisons. A computer can take and analyze morphological differences or shape differences. In addition, the computer has the ability to take all of the other information and analysis associated with the acquired data to go beyond just shape and be able to discern whether the statistics show that this is a probable cancer as opposed to a benign tumor. So the computer analyzes more data than just visual data to see if a tumor is benign or malignant. Taking all of this data into consideration and communicating it to the interpreting physician or radiologist, the radiologist has a better opportunity to make a more accurate decision. The ability for the computer to accurately sort the data and provide communication to the radiologist makes it an excellent tool to use in interpretation of medical images. Remember, without computer data, the radiologist is limited to their visual interpretation of the image, just as we were in the past in film screen medical imaging. We take a look at the performance and the amount of data. You can see readily that deep learning actually is able to do more data in quicker time with a better result. Here we see the components utilized for analysis in deep learning. They are pixel depth and pixel data. Plus we look at the photometric interpretation of the metadata. There's multiple sorts of all of the data and integrates the information to create an answer for a question or to provide the information that the radiologist or interpreting physician seeks. Let's take a moment to take a look at a block diagram of a generic content-based image retrieval program. CBIR, or Content-Based Image Retrieval, is a way of searching image database using visual features of an image as a search term to find images that share the same visual features. The content-based image retrieval system is comprised of two components. The first is our local network or offline component of the system. We can think of this as being our office or hospital, where we take the images, we process the images, and we store the images. We use images created locally and stored in our database to find the images that share similar visual features to the image that we're analyzing. After searching our local database, we go online and take a look at the internet database and search it as well for images that share similar visual features. We take the images that we have searched online and incorporate them into the search that we did in our own facility, thus building a database of images for research and comparison. We've now created a database of images with similar features to be able to search and create our new image. Now we filter this data. Basically, we redefine it multiple times, narrowing our search to get to the specific questions that we needed answered. The interpreting physician then takes the data that they have acquired locally and compares it to the data that they have researched. From this, they can make a decision or an interpretation. Here we can see the methods of comparison. We can start with the CAD or computer-aided detection that we've done for 10 to 20 years. Using CAD as a basis, we then progress where we're utilizing segmentation, visualization, and quantification or quantitative image tools to further aid in diagnosis. With superior technology to the quantitative imaging tools, we get automated workflow capabilities, which helps us in our decision support tools. Automated workflow takes most of the labor out of the process. Using today's technology of deep learning, we've gone from detection only to a differential diagnosis in our computer-aided diagnosis program. Let's review segmentation of this brain MRI. We begin by an acquisition study of the brain using MRI as our modality. We acquire images in all three planes, axial, sagittal, and coronal. We then combine these to create a solid block of data. Utilizing this solid block of data, we can select information at any angle and different slice thicknesses. We'll begin by creating what we call convolutional levels or layers. What these are layers that look at the morphology or the actual physical contours that we want to record. Here you can see the three layers that we're recording data. One is for the brain boundaries. The next is for the gray matter and ventricles. And the third is white matter and abnormalities. We then integrate this data to create a classification layer of the brain. This would be our primary image. After we've created this primary layer of information, what we need to do is to segment it or actually put it into different parameters that we're searching for. We then take this information and do a content-based information retrieval. This allows us to get the information to make a differential diagnosis between the image that we created and the information about the images that are similar. After we've made our interpretation, these images are then stored in our local database system. We can manipulate the data in a number of ways. We know that there is a lot more data stored in MRI than there is in a CT, so we have a lot more information. We can take the information that we've mapped from the MRI and use different lookup tables to make a synthesis of a CT image for the same level. Because there is less data in the CT image, we cannot reverse this process and make a MRI slice from a CT slice. You must have enough data and information to make an image. Another post-processing technique is that we can annotate an image automatically so that we'll be able to cascade the animations on the image and make it easier for a clinician who has ordered the image to visualize the interpretation and see where the pathology lies. Given the stored data that we have acquired, we can select data and create images in a myriad of ways. Imaging informatics and imaging modality technology is continually evolving. This rapid evolution of technology and information has put more emphasis on doing continuing education, such as this course, to keep abreast of what's happening. Well, this is Mark Struthers, and I wanted to take a moment to thank you for your time and for your attention.